Dr. David Attia. Welcome to the Graduate Dentist podcast.
Thank you, Erica.
This is something a little bit different because I guess normally it's me talking to my guest. We're both on Zoom and there isn't a live audience with us. But I wanted to do this in person because I want you guys to be able to be a part of it and for us to get to, ask the questions that you've all been wanting, that you're listening. When you're listening to me in the car and you're just like, I wish you asked that question, but you didn't. So now's your opportunity to continue to send those questions through Slido, and we're just going to dive into it and answer all of them. But I think to start off with it, I guess I want to give people a bit of context about what you do, where you're at. So most people know who you are, but can I get a bit of an introduction as to who you are and what you do day to day now?
So my name's David Attia. I can see some familiar faces from people who've come to our courses or the diploma. I'm a general dentist. I'm based in Sydney. For the longest time, I did a fair amount of general dentistry up until about 4 or 5 years ago, where I started to hone in and focus in on surgical dentistry. I was traveling at one point to about 14 practices every month, meaning I spent 1 or 2 days a month at each site, taking care of their surgical needs, from wisdom teeth removal to implants, bone grafting, gum grafting, sinus grafting, full mouth reconstruction cases, and that sort of thing. And up until about a year ago, I joined Johan and his business partner David, and we established the Smile Artisans here in Sydney. And that's sort of where I'm at now. I spend about 4 days a week there. I still do a little bit of referral work. I spend a fair amount of time mentoring dentists, whether it be through the ACDP diploma or dentists who reach out through social media or through DPR and send a message saying, hey, look, I've got a couple of cases coming up. I would love some, hand holding for these cases. And we sort of see where they're at and help as much as we can. Yeah.
Yeah, I wanted to, I guess, bring you on specifically, David, and have a chat with you because a lot of our presentations and talks today have all been about, master your basics, learn the fundamentals, crawl before you walk before you run before you fly. But we will always have the go-getters. We will always have the people that have these big aspirations. And I think, as part of our message of always wanting to guide people is it's okay if you have those aspirations, but we want to do our best to ensure that if you do have those aspirations and you want to get into the fancy work, you want to get into implant dentistry, how can we do it safely? And I guess someone yourself who has done so much just training, but also in particular done so much mentoring and teaching, imagine you've kind of seen the whole spectrum of people at every stage of their career, what they've done well, what could have been done well, and I guess reflecting on your own personal journey as well. So before we tap into, I guess, mentoring people and advice for others wanting to get into it, can we tap into your journey?
Mm.
And did you always want to be, I guess, a dentist with a special interest in surgery?
I think from the uni days, I was very surgically driven. Even when I was on placement, I would go into uni on the surgical days to watch the oral surgeon or to, book in a couple of extra surgical extraction cases whilst I had the chance at uni. So heading down the following graduation, heading down the path of what do I want to do? What do I want to spend most of my time on? And before I graduated, I sort of had in my mind that I really wanted to spend time doing orthodontics and surgery. And 3 months out of uni, I signed up to an ortho diploma. And whilst I don't do a lot of orthodontics now, orthodontics does form a big, big part of what I do clinically, surgically. It formed the foundation of what I really do. So after going through about 18 months of literally putting braces on everyone that walked in with a pulse, I realized I realized that this is not what I want to focus all my efforts on. I was in a group practice where, everyone had sort of their own little niches. I was a young associate dentist, hungry at the time, and really just wanted to get into doing more orthodontics, more surgery, more implants. But I had to start somewhere. And it really did start with restorative treatment. And I did a lot of restorative until I finished that ortho diploma and realized whilst I enjoy this, I don't want to be doing this all the time. I also acknowledge the fact that I can't be good at everything. I can do certain things to a level that I would think is acceptable. And maybe my colleagues or a panel of my own peers would say, you know what, that's above average or that's acceptable by today's standards from a general dentistry perspective. But I really realized that there's many people out there that can do this stuff way better than me, right? I'm fortunate to be surrounded by dentists who do crown and bridge, ortho, restorative to a way higher standard than I ever did, right? And that's the likes of Johan, the likes of Barat, and the people that I've fortunately stumbled across along my journey. There was times where I didn't have a lot of surgery. Like I was in Townsville and it was frustrating because a patient that needs an implant walks in and everyone in the practice is like a hyena waiting to jump on the patient, wanting to do the implant. So there were periods of time where I was really, really not filling that void of wanting to do more surgery, but I had to make do with what I had. And that really led me to sort of documenting everything, documenting all of my cases from class one restorations all the way up to crown and bridge work, extractions, etc. And really critiquing those things to make me still love dentistry, right? We all have a passion of something, whether it be restorative, ortho, surgery. But as general dentists, we need to understand we're not going to get our full books full of that one thing we love unless you go and specialize, right? So I guess to stay on track for that, continued discipline in improving and, being better than what you were yesterday, it had to start really with general dentistry.
Mhm.
And that discipline trickled over into implants. And that led to me documenting a lot of implant cases. I had done some weekend courses, I'd done some live surgery courses, and I then realized that, hey, I need to really, really spend a lot of my time doing this. And I did a structured program. I did a 2-year master's degree in Germany, and that was intense. That was 4 trips to Germany, 10 days, straight lectures from 8 o'clock to 7 o'clock every single day for 10 days straight. The flights, the jet lag, the time off work, the reduced income, et cetera, et cetera, et cetera. And when you immerse yourself in something like that, I feel like you gain an appreciation for the intricacies of that discipline that you have no idea about. The more you learn about something, the more you realize that there's so much more to learn. And a lot of people think that that master's degree was the end of my education. It was the beginning. It really, I think what I took most from that was the critical mind. A company comes and presents you with something, or a dentist comes and tells you to do something, you take it with a bucket of salt, not a grain. You take it with a bucket of salt, right? And then you really look at and critically analyze the information that's presented in front of you and make your own informed decision as a clinician of whether this fits in with your practice ethos, whether this fits in with your patient demographic. What might work for a patient in Townsville might not work for a patient in Sydney. I've got patients in Sydney that don't want to be without a molar, not even for a day, right? And I got to provide them a temporary. I got to manage their expectations. Townsville, people walking around with no front teeth, and it was socially accepted. It was almost in. So it's really, really important to be able to critically analyze and really tailor your skill set to the demographic that you're placed in. And ultimately, what I feel is that sort of reverses in that you attract the patients that buy into your philosophy, that
100%.
buy into your treatment modality, right? So yeah, I found myself when I was moving back and forth from Sydney to Townsville. I used to travel once a month to work at an orthodontic practice when I was doing a lot of ortho. And I would be seeing 40, 50 patients a day just to up my skills. I wasn't getting paid. I was doing it for free, covered my own flights, my own accommodation, all that sort of thing. And it was just for the pursuit of getting better at orthodontics. But during that time, I was also doing some surgical work for a couple of friends' clinics. And that meant I was getting more reps in. It meant I was seeing more cases. It meant that I was able to treatment plan a lot more. At the same time, I had surrounded myself with mentors who were able to look at the cases with me. I was in a practice where my mentor was in the room next door, and it was great. He was there for the first 40 or 50 implants that I placed, literally in the same room. He was always a phone call away or a text message away. And even whilst I was in Sydney doing cases, we were discussing the cases, right? And that really helped. It gave me a little bit of assurance that I've got somebody more experienced looking at my cases. When I moved back to Sydney, that wasn't there anymore, and it was like the training wheels had come off. And I always use this term, that psychological dependence, right? I had psychological dependence that in the room next door, if something went wrong, I had somebody there to come in and jump in. Now, when you're on your own, traveling to 4, 5, 6, and eventually 14 practices or somewhat, there's no one there. You're by yourself. Talk about an isolating career. add complex procedures that are highly stressful, that can potentially do harm, I found myself with no more dependence on anybody. And you sort of look around and it's just you and the four walls and the nurse, and there's blood squirting across the room, and you're like, what do I do here? And really, what happens is you have to come up with a solution, right? And you develop thick skin, but at the same point, you understand where the lines are, right? And I was only able to do that because of the 40, 50, 60 implants or hundreds of cases that I did with somebody in the room next door, right? And I was very lucky. I always say this, like Johan's journey is quite different to mine. And I think it's actually more extraordinary because he went through the journey without a mentor, right? Whilst he had mentors that were not in the practice, it's very different having somebody in the practice, right? Like that's a far harder journey. But at the same point, he didn't go ahead and run into cases that he wasn't able to do. Maybe I stretched the boundaries a little bit, having somebody in the room next door, knowing that I had a bailout, right? And you might be in that practice where you've got somebody next door who can bail you out. But I think with that comes a responsibility of knowing where you should draw the line. There were cases that I would refer, block my book, and assist. Make no money that case, assist for 4 or 5 cases of the same procedure, watch, learn, and then the next couple of cases, the business owner at the time was kind enough to block out his book and sit with me during the procedures. And then we would debrief and we would go through what went right, what went wrong, what could be done better, right? We have this tendency of looking at our cases and spending a lot of time in the glory that comes from those cases. I want to challenge you to look at the glory of the cases for 5 minutes, but then spend 5 hours analyzing what could be done better. Because ultimately, that's how we get that 1% better every day, right? Things look very different through a pair of loops than a 65-inch screen where all your imperfections are on display. And you got to be really, really objective and critical. And the photos don't lie. I mean, Photoshop does, but the photos that you take that are raw straight off the camera do not lie. And one thing that Bharat said to me, I think probably a year out, was don't post all your work on DPR. Because every man and his dog is a keyboard warrior sitting behind a keyboard who'll give their 2 cents and their opinion. If you need help with a composite, send it to somebody who does composite. If you need help with an implant, send it to somebody who does implants regularly, right? And find that close-knit group of people who are going to give you the hard truth that you need to hear. You might not want to hear it, but somebody's got to be there to tell you the things that you don't want to hear, because we can often be blurred or be distracted or be deceived into thinking that what we're doing is the standard, when somebody more experienced might look at it and say, hey, look, that's 80% good, but here's how you can take it to 95. And here's how you can take it to 98. Or here's how you can improve on the next case.
There's a lot that comes with leaving university and properly adulting that no one really prepares you for. As a new grad with an income and newfound responsibilities we don't know what to do with, managing finances can be really tough. That's where JS Medical and Dental Finance comes in. Specializing in financing options tailored to medical and dental professionals, JSMDF is a completely independent broker dedicated to finding the best bank and lender for your unique situation. Led by the incredible Jason Savage, who personally came to my rescue and worked his magic and helped me secure a loan before I even started working, JSMDF is committed to supporting you throughout your personal and professional journey in whatever way you need. Whether you're looking to buy a house, a car, a practice, or pay off that year-long CPD course you signed yourself up for, JSMDF offer comprehensive advice tailored to your short and long-term plans. Their goal is to be with you from day one and thoroughly understand your financial needs and provide solutions that best work for you. And so if you're looking for some advice or you simply want to explore your options, get in touch with Jason and his team. A big thank you to JSMDF for helping make being an adult that extra bit easier, and for supporting the graduate dentist community. I really love you bringing up the concept of mentorship. And it's actually something that I wanted to dive into with today's conversation because if you guys were all following with the Instagram over these last few days, I've been talking about mentorship and posting all these polls and getting all of everyone's input on the level of mentorship you want as a new grad, particularly when tackling bigger cases. And then also, and look, maybe controversial, but I think it's important to talk about it openly, is the remuneration of it. And there was such a big divide. I don't know if you guys saw the results, but for those that haven't seen it, I posted an Instagram poll because I'm speaking at the Dental Practice Owners Conference later this year in August, and it's all about the expectations and motivations and desires of new grads. And I asked, okay, what is the main thing that everyone wants as a new grad? Everyone wants mentoring and support. Okay, what level of mentoring and support do you want? Everyone's like, I want chairside mentoring and support. And then I asked, so who gets paid? They're like- And a lot of people said, I want to get paid.
Mhm.
And I'm usually a very diplomatic person, but this upset me. And I felt that, and look, I think there's nuances
Mm.
to it. And I think there are some environments where practice owners do exploit their new grads and do take advantage of them. But I'm very passionate about like, if you want to learn and you genuinely want to do what's right and you want to do what's right by your patient, money should be the last thing you're thinking about. And particularly if you have a mentor who's going out of their way to look after you, to guide you, like, you shouldn't be expecting to be getting paid for it. Like, if your mentor doesn't want to take the billings because they want to share their time, I think that's fair. But as a grad, if you want to learn, like, your mindset should be like, I'm wanting to learn. Um, can I dive into when you talked about your first cases? And maybe we can expand on this because I feel like I've given a bit of an abridged version of all my thoughts on it. But Dave, what I really liked was you saying that your first 50, 60 implants were done with guidance, with assistance, with someone next door.
Yep.
And I think perhaps there's a bit of a disconnect where some people think I can do a weekend course and then go in straight away and place them by myself.
Yeah.
When you first started getting into implants, what was your experience and how do you remember your very first case and what it was when at what point you did it? Can you tell us the full story?
Look, I think planning the cases with the principal dentist was always something that was going to happen. End of the day, they were his patients, his goodwill, his practice, his name on the front door. So ultimately, whatever I did was going to come back to the practice. Even though I was going to be there for 3 or 4 years, complications, as we were talking, Annalyn, come back at 5 years, 7 years, 10 years. Now, I've been fortunate enough to be at 14 practices, 12 of which I've been at for 6 years or more. So I've seen the good, the bad, the ugly. And for the most part, our work holds up. Our work is considered successful. But I think with that on mentorship, the first few cases were really, we sat down, we treatment planned, we took pre-op records, we spent the time to develop a surgical plan. We wrote down that surgical plan. We wrote it down on an A4 piece of paper and taped it to the screen in front of the patient. Everything. Local anesthetic, check. Now I can move on to the next thing, right? If you don't have a surgical plan, when you're doing your first, second, third, or even 10th implant, you probably haven't slept the night before. You've stressed. You haven't put in a plan A, a plan B, a plan C. You walk in with this surgical complacency. I'm going in, I've planned a 5 millimeter by 10 millimeter implant. Regardless of what happens in the surgery, a 5 by 10 is going in. Whether the ridge is 3 millimeters, 10 millimeters, whether the nerve is close or not, a 5 by 10 is going in and you have no flexibility, right? And you learn real quick that if you make compromises based on a pre-surgical plan without factoring in what can or can't go wrong, you'll find yourself in hot water quicker. And that's where somebody else there who hasn't got that stress that you've got during the surgery. When I'm mentoring dentists, I'm looking at the case from a completely different perspective. I can see they're sweating. I can see they're stressing. I can see that they're waiting for me to give them some form of direction, right? But at the same point, if I'm not there and they're doing that case on their own, my worry is that if they don't have anyone around them to give them that direction, then they're going to do exactly what I just said. They're going to place that 5x10, even though it shouldn't go in. They're going to place the implant when they probably shouldn't, because the patient's taken time off work, the patient's already prepaid, the surgical guide's been made by some lab overseas who hasn't looked at the patient, spoken to the patient, discussed the case. Anyone can sit behind a computer and plan a guide for you, right? But being able to read and react to surgery on the go is something that's really, really important. And let's face it, I never had that during the first 50, 60, 100 implants. I had a plan A and maybe a plan B after 20, 30 implants. You're like, all right, well, this might go wrong. So if this happens, then I'm going to do this, right? Now I'll walk into a case that needs a 5x10. I have a 4.3x10. I have a 4.3x8. I have a 5x10. I have a 5x8. And in severe circumstances, I've got a 4 and I've got bone grafts ready to go, right? Because I've treatment planned this patient 3 months ago, maybe. Things change over time. I walk in, the case is not exactly what it presented to be based on the information that I had. And mind you, I was at 14 practices. I was reviewing 100 to 150 cone beams every week, sometimes at 11 o'clock at night, right? And once you click on a cone beam, you're responsible for that cone beam. So I drew a hard and fast rule about getting every single CBCT that is sent to me via Dropbox, SMS, WeTransfer, whatever, to be reported on by a maxillofacial radiologist. I'm not qualified enough to look at a cone beam. You think you are, but there is so much that can be missed. So I'm adding another layer of somebody else looking over my shoulder, even to this day, that looks at the cone beams beforehand and says, hey, maybe you shouldn't consider placing this implant because even though you're looking at this area, you haven't looked at the whole picture. You're so focused on that 4-6 implant or that central incisor implant that you haven't looked at the bomb attack that's occurring in the other quadrant, right? So really having that person in the room next door helped. And look, we're in an era where social media is a double-edged sword, right? A lot of my mentors now are not in Australia. So I use social media for the good that it offers. I've made contacts with hundreds of perios, hundreds of maxillofacial surgeons overseas. And we're in group chats and we share cases and we get opinions. Imagine a group chat with 40 maxillofacial surgeons who each have 10 to 15 years, maybe 20 years of experience each. Math. That's 800 years. What is it? Is that right? 800 years. 20 by 40, that's 800, right? Yeah, 800 years of experience combined into one group chat. I've only been doing this for 8 years, 10 years. I'm barely even out of the womb in that group chat. But it's another checkpoint. It's somebody else that can help. It's somebody else that can give their opinion. And going back onto what Bharat says, it's not just a post on DPR and getting everybody's opinion. No, no, no. I'm speaking about a very, very specific case with very, very specific requirements, with a very, very specific skill set required, doing a very, very specific procedure, getting help from people who do those cases every single day of the week. It's a big difference to posting a case on Instagram and expecting everyone to give you the answers that you're looking for a case. I think we went on a bit of a tangent.
Yeah. What was your first implant?
So the first 2 implants that I did, my boss had broken his foot. He was in a moon boot and it was supposed to be under a general anesthetic. The anesthetist was late. He was flying in from interstate. His foot started to burn up during the procedure. So he took the moon boot off, put it in an ice bucket and was literally suctioning while I did the first 2 implants. Now, funnily enough, that was also my first free gingival graft 5 years later. So what we knew 5 years ago or 10 years before wasn't considered. Fortunately, the implants were still great. The bone levels were still good, but it needed some additional care later on that probably could have been avoided if it was done properly the first time. So those first 2 implants were 3435. I still remember the patient's name, still remember exactly how the day went. And yeah, I just remember the ice buckets.
Did you have much training at that point in time before going into your first implants? Obviously, you had your boss who was there, chairside guidance, albeit with their moon boot. But what had you done in terms of, because uni doesn't prepare you for it.
No. Look, before I did my first implant restoration, I did do an implant restorative course. It was a 1-day course. It was the fear of litigation, right? Even though it's just taking an impression of an implant crown, once I put that crown on, I'm the one responsible for it. I'm the one that said it's okay to restore. So I did a CPD course on implant restorative, and then before I moved to Townsville, I was advised to do a live surgical training course, and I did. And it's important to take the good from those courses and understand the limitations of those courses. I would send X-rays of the cases that I did overseas, and the responses I was getting was, "You're not doing those type of implants in my practice," right? But it was about getting your hands in there, feeling bone, reflecting flaps, placing your first implant, and look, in hindsight, would I do it again? Maybe, maybe at a later point after I'd built up some theoretical knowledge, maybe. But I also had in the back of my mind that I had somebody there when I came back. If you told me you were going to go to that live surgery course and come back and start doing implants in your own practice, there's no way I would have felt confident. No way. Right. So, one live surgery course, a couple of theoretical courses to do restorative and maybe basic surgical skills, and that was it. But I had that wealth of knowledge in the room for the first 30, 40 cases.
I often say on the podcast that the more I do, the more I realize just how little I know, and how dentistry is just one of those careers where you never stop learning. But let's be real, getting the right training can be expensive, time consuming, and sometimes just straight up overwhelming. That's where Ripe Global comes in. Founded by Dr. Lincoln Harris, Ripe Global is completely changing the way that we learn. They offer immersive, hands-on training that actually fits into your life. Whether it's through improving your preps, getting faster with composites, or tackling more complex cases, you'll be learning from some of the best clinicians in the world without having to take time off work or spend thousands on travel. And so if you're serious about upskilling and boosting your confidence in the clinic, check out Ripe Global today. Hit the link in our show notes and let's start learning smarter, not harder.
Yeah.
I guess in hindsight then, had you not had that safety net already there, or your advice to young dentists who want to get into it, what would you do differently? What kind of courses, don't
Mm.
need to plug specific courses,
Yeah.
but I guess what kind of course or what fundamental skills,
Mm.
treatment planning, surgical skills, do you think you should have almost as that same checklist before you start diving into?
Yeah. I mean, outside somebody asked me a similar question.
Yeah.
I'd probably take a page out of Johan's book
Mm.
in the sense that for the first 5 or 6 years, because he didn't have the mentor, he didn't have that, psychological dependence on somebody in the room next door. He focused on building the healthy, meaningful relationships with his patients, doing the dentistry that he could provide until essentially he came full circle and he'd known these patients for 4 or 5 years. When he was ready to do the comprehensive dentistry, so were they. So it just happened to line up. Nowadays, I would probably say learn how to take teeth out. A lot of dentists do not know how to take teeth out. I mentor a lot of dentists who are older than me. And I'll be like, let me just give you a couple of tips with that extraction. I've been doing extraction since before you were born. I know how to take the tooth out. And they take the tooth out the way they were taught at uni. Pick up the biggest forceps you have, pull as hard as you can in whatever direction you need to get the tooth out. Focus on learning how to take teeth out in the most delicate possible way. That sets you up for so much more success, right? It sets you up for socket preservation. It sets you up for coming back in 4 months' time if you don't do socket preservation and being able to plan a case that has sufficient bone, undamaged soft tissue, with the foundations of a case that can be done without any auxiliary procedures that are more complex, more technique sensitive, more demanding, more expensive, more traumatic for your patients. And it all started with focusing on the extraction, right? When we teach the socket preservation course, whilst this sounds like a cliche or too good to be true, dentists can walk out after learning how to take teeth out, how to do socket preservation to a very high standard, able to tackle on 80% of cases that walk through your doors. 80% of simple, single, straightforward implants can be tackled if you know how to take teeth out and with a couple of extra skills in socket preservation, how to build bone at the time of extraction, and you'll have the most stress-free implant career. You'll have far less gray hairs than me. And to be honest, 4 socket preservation procedures are more profitable than all on X. But for some reason, everyone puts all on X on this pedestal like this is the holy grail of implant dentistry. I can tell you right now, a simple, single, straightforward posterior done to perfection is harder than all on X because it's about the details. A single central, and like I said, you attract the patients that match. I get a lot of single central referrals, right? More stressful, higher patient expectations, but they are far more harder or technically demanding than all on X. So I do think if you master the skills in atraumatic extraction, being able to preserve sockets, or even if you don't do socket preservation, being able to just preserve the hard and soft tissues at the time of extraction, you will find yourself in a far better position 3-4 months down the track when you're ready to place the implant. Because you don't have to do complex procedures. You don't have to do expensive procedures for your patients. More often than not, it's as simple as placing the implant inside bone and just some very, very basic flap manipulation to get the gums in the right position. And most of those cases will be successful.
We've had quite a few questions come in, I guess, specifically about atraumatic extractions and about socket preservation. And I think perhaps this relates to treatment planning and communication. But as an example, you oftentimes have that emergency toothache patient that comes in, needs a tooth taken out. Say this is a molar and you only have half an hour, 45 minutes to do it.
Mhm.
You know that maybe it takes you a little bit longer to, you're a new grad, you don't know if you should section it, remove it, like surgically to be as atraumatic as possible, whether you do a socket graft. Like, how would you recommend a recent grad take a step back and plan that kind of case?
So, really simply put, any multi-rooted tooth, section. Not so you can charge a 324, right? Any multi-rooted tooth, section. Let the forces work in your favor. When you have 2 roots that are splaying in 2 different directions, the tooth's not going to come out. When you section the tooth and divide it into 2 single-rooted teeth, it becomes a very, very simple, straightforward extraction.
Do you think every socket needs to be grafted?
I don't think every socket preservation needs to be grafted. I think socket preservation provides us with a very, very good opportunity to avoid complex grafting procedures later. And the literature tells us 1 in 24 socket preserved cases requires further grafting. I'll take those odds. If it means I'm socket grafting something as simple as putting a bone graft inside an empty hole and learning how to curette, clean, degranulate, preserve the site, and come back and have a 1 in 24 chance that I need to do further grafting, I will take that every day of the week. Because I put in all the effort in that socket preservation appointment that you have 5 simple, straightforward, single, stress-free implants that can be done with high success and high predictability because you've followed the protocols of extraction, socket preservation, and then timing of re-entry, surgical guide planning with somebody who knows what they're doing, etc., etc.
Yeah, that kind of answers, I guess, a question that someone asked specifically, where they said there's a fair amount of the community that believe socket preservation techniques aren't very effective. Is there any validity in this idea? And I guess kind of.
If I had my MacBook, I'd open up and I probably got over 250 socket preservation cases documented from start to finish
Mm.
with up to 4 or 5 year follow-ups on a fair few of them. And I've got 7 or 8 year follow-ups on some. Now, this is just anecdotally. I'm not saying this is gospel. Take it with that bucket of salt that I told you about at the beginning. But this is what we do day in, day out. And we've been around to see the 5 and 6 year follow-ups, right? And it works. I teach with Dr. Chris Ho, specialist prosthodont. He doesn't do much socket preservation, but comprehensive, complex guided bone regeneration in his hands works to a very, very high standard. Socket preservation works in my hands, and it means that I'm minimizing the number of surgical interventions. I'm minimizing the complexity of the grafting procedures. And whilst I do them, I do very little of them.
Mm.
Probably, I would say 5% of cases, I would do comprehensive bone grafting cases. And that's because those patients had lost their teeth 5, 10, 15 years ago. If I'd seen them before the tooth was removed, it would be a socket preservation most of the time. The cases where you don't need socket preservation are these unicorn patients that don't grow up in Sydney. They grow up near a nuclear power plant somewhere where the bone is so thick that regardless of how much you butcher the extraction, there'll still be bone left after you've taken the tooth out.
You mentioned before about sectioning teeth, and you would section, was as a rule of thumb, any multi-rooted tooth. How do you section an anterior tooth when there's only one root?
Okay. So if you're luxating that tooth and it's not moving, or as you luxate it, you're feeling pressure on the buccal plate because your finger is always on the buccal plate to see where the tooth wants to go. Conventionally, you would section teeth lingually, right? To give you a mesial and a distal portion. It's exactly how you'd section an anterior, right? You would section it from the palatal to the buccal to separate it into mesial and distal components. And that way, when you luxate, there's no pressure on the buccal plate. You're dividing the tooth in a way that the forces become favorable in preserving the hard and soft tissues to the best of your ability. Sometimes the buccal plate still fractures. If you know how to manage those types of sockets in terms of socket preservation, then it makes no big difference in whether or not you get a small fracture in the buccal plate or not.
Yeah, I think as a summary of kind of what you've gone through just then is, okay, first step if you want to get into doing surgeries, one, building those relationships, doing basic, skills, learning to take out teeth atraumatically, and perhaps learning how to preserve these sockets. Then, okay, we've kind of got those fundamental skill sets under our belt, and you want to dive into implants, right? What kind of courses would you recommend? You said before those live patient surgeries. Is a weekend course enough? Is one course enough? Do you have to do every course? And how does someone get into
I think
learning?
it's very difficult for you guys now with so many
Yeah.
courses available, right? Everyone's an educator today, right? It's so difficult to discern and find the right courses. I would say do as many courses as you can, both financially, time-wise, etc. End of the day, we have lives, most of us, right? You can't do every course because financially that's just unrealistic. And at the same point, I know a lot of people who've done courses, infinite number of courses within 12 months. Well, where's the time to apply the knowledge that you've learned from those courses? How do you know what works and what doesn't work? How do you know if you've been able to apply those skills, right? So, look, I would do weekend courses are not bad. Weekend courses give you an idea of a procedure. They give you an introduction to be able to understand the fundamental skills required to execute something, right? But at the same point, that's only going to get you so far. Courses coupled with in-house mentorship, if you have a dentist there who does the procedures, etc., and then really blended learning. Like I can't. There's no other way to really put it. If you want to head down a surgical path where you want to spend a lot of your time doing surgery, then I would think some form of tertiary education or blended learning is critical. Whether it be a postgraduate diploma through university, whether it be a postgraduate certificate, whether it be, I don't know, a master's program, I would think some form of blended learning will really help cement the foundational knowledge. Will also open your eyes to what is possible in implant dentistry. It's changing every day. Like what we knew 5 years ago is not what we're doing today sometimes. And it's really important. I mean, one quote that one of my mentors said in Germany is the knowledge of today can be the error of tomorrow. Like what I'm doing today may not be what I'm doing 5, 6, 7 years from now. So being able to develop that foundational knowledge, because biology doesn't change, but also coupled with that critical analysis of education, knowledge that's presented to you, and then, yeah, discerning what's actually worth changing for and what's worth continuing to do.
It's what you were saying before, like the more you started doing it, the more you learned, the more you realize there's so much more to learn. Hey? When we talk about mentorship, then if you don't have that in-house mentorship and that support, how do you go about seeking that guidance then?
Look, some programs will offer mentorship
Mm.
as part of the program. I mean, for my master's degree, I had to submit 20 cases fully documented. 20, as in like 2 anteriors, 2 posteriors, 2 maxillas, 2 mandibles, 2 lateral wall sinus lifts, 2 anteriors with gum grafting, a whole spectrum of cases, right? If you don't have that in-house mentorship and you don't have a program that's doing that, seek it out. Seek it out. I paid a lot of money for people to come into the practice when I was in Sydney to hold my hand for certain procedures, right? And for me, it was my form of CPD, right? Costs a lot of money sometimes, but I weigh up the pros and cons of paying that kind of money to get the mentorship, to get that one-on-one chair side, and obviously the communities that you develop. I think the Discord is a great way of getting a bit of advice. I don't think we can learn these types of procedures on Instagram and on Facebook. And it's almost become an expectation with Gen Z. I would get an x-ray and say, tell me what you would do here. It's like, is this patient a male, a female? What's the rest of their teeth look like? I'm looking at one x-ray, one PA. It's not even a CBCT. I'm looking at a PA of a tooth. I can't really give you an answer because you're going to hold me to it. And at the same point, have you done the appropriate record taking and discussions with your patient to see whether they're viable? You know, so the groups really do help in at least pointing you in the right direction. And yeah, I think, look, align yourself with specialist colleagues who genuinely want you to improve as a GP. It's a very thought out sentence, right? We're lucky that we're surrounded by specialists who see our work and say, okay, this guy's not a cowboy. And guys, I'm not trying to say that I don't have complications. We all have complications. And, you know, Johan and I are very open about our complications, especially with each other. Annalene wouldn't. I got Annalene on speed dial, right? Not because I call her a lot, but just in case I need to call her, right? And really having that support from somebody who can objectively look at one of your complications and say, look, David, this is what you did wrong. Whether you want to hear it or not, this is what you did wrong. And a lot of the time, if you are self-critical, you will develop your own understanding of where you went wrong deep down, even if you can't verbalize it. As long as you know where you can do better, then you're going to improve on the next case. We're only as good as the last surgery that we've done.
You all know that if there's one thing I am super passionate about and always advocate for on our podcast, it is our mental well-being as dentists. There's no denying that our profession can demand so much from us, and it can drain us physically, emotionally, socially, and mentally. And some days it can all just feel a little too much. This is where our friends at Dental Practitioner Support come in. Whether you're new to dentistry or have been practicing for years, Dental Practitioner Support is here to offer guidance, reassurance, and a safe space to talk about whatever it may be that's weighing heavy on your heart. They provide 24-hour services that are completely confidential and independent, so you know that you will always have someone to turn to. Whatever your scenario may be, Dental Practitioner Support is just one call away. And so, in case you ever need it, save the number 1-800-377-700 or visit their website at dpsupport.org.au. Remember, as we say time and time again on the podcast, you are never alone, and we really are all in it together.
I want to dive into your comment about complications, and we spoke the other day about sharing some cases or some anecdotes about that. But before we get to that, I think building on, it's got quite a few questions about this mentorship and finding your support group, and I touched on it before as well. But you mentioned that if you don't have someone there in house looking after you, the question is, did you pay a dentist to observe their work? Or I guess perhaps the question is around how do you go about building that connection to, I think before you touched on as well that you used to go block off your books to go watch someone else do your cases and then them coming in and helping you. I guess can you expand on those relationships and that?
Yeah. So
Mm.
I think mentorship comes in a number of different ways. I think observation is definitely one form of mentorship. Observing cases. Doing cases with somebody there is something that I did a lot of. Yeah. So I observed first, got an idea of what the procedure is, got an understanding of how complex. Sometimes it's not the procedure, it's everything that goes with the procedure, from nurses being set up, equipment being available, sterilization techniques and protocols. All of these things make the procedure what it is. So I guess when you watch a procedure and you've got no stress on you, you have no obligation to that patient, you are just there to observe, you take a lot more than if you were doing that procedure for the first time in an environment, even if you had somebody there. So when you observe and you see how the nurse coordinates with the dentist, or how the two nurses work in coordination with each other, how the room is set up, how the flow of the procedure takes place, how that dentist communicates with the patient, right? I used to be very, very shy about talking about complications with patients. Like, I couldn't make eye contact with them. I'm talking about, oh, this implant might be failing. There's a chance that this implant fails. Or, now it's dead center, looking him in the eye, saying, one patient said to me, why do you always start with the bad? Because I can easily sell you on the case with the good. You need to understand what can go wrong, because we're all human. Sometimes things just go wrong and you can't control it, right? We use this analogy sometimes in our practice with our associates. Every procedure that you do in dentistry is like a clothesline. Every single factor that can contribute to failure is a coat hanger. How many coat hangers can you put on that clothesline before it falls down, right? So I'm very type A. We control as many coat hangers as possible. So when things go wrong, I know that these coat hangers were not contributing to the failure, as far as my knowledge, and it helps us to identify where things have gone wrong. Okay, this concept was introduced to me in Germany. It was the first slide that he put up, my mentor, Paul Weigel. Understanding what factors contribute to failure allow us to control those factors and therefore minimize the possibilities that can contribute to failure. Whether it be patient medical history, prosthetic issues, surgical duration, suturing, osteotomy protocol, etc., etc., etc.
Mm. So I guess to kind of circle back on that, a good starting point is if you've got a case that you can't do yourself, but you want to learn more about, it would be perhaps referring it, finding, you don't necessarily need to be someone within your practice, but someone you built a relationship with. You've referred that patient to them
Yep.
to treat.
Yep.
You've gone in on your day off, block some time out to go watch them and just soak all of that in. And then do that for a number of cases, and then perhaps evolve into tackling it yourself,
Yep.
whether you would bring that dentist in to come help and support you. In terms of building that relationship and trying to seek proper advice, what kind of documentation helps? Well, you said before a PA doesn't help. What kind of documentation actually does help when having that consult with a dentist you might refer
Yep.
your work to?
I think good quality photos. When we're talking about implants, either refer the patient for a cone beam CT, or take a CBCT. Provide the dentist that's doing the procedure with photos, CBCT, patient's relevant medical history. And remember that, as Dr. House said, patients lie. So you need to really dig deeper into the patient medical history side. Ask them the questions and follow-up questions, because often patients will give you a half truth or half the answer. And they're not necessarily doing it to lie to you. They just don't know what's relevant, right? We're ultimately the clinicians, right? So CBCT, photos, patient medical history as a minimum, I would think. Yeah.
I've got two more questions that I'm going to ask before we wrap this up. I really like this question, and I would love to hear your experience with it, having gone and done a lot of mentoring as well, or being on the receiving end, is how do you have that conversation with your patient in that there is someone in the room who is guiding you? And how do you do it in a way where you don't, I guess your patient doesn't lose confidence in your
Mhm.
capability?
Mhm. Depending on the stage of the career that you're in, I think makes a difference. So, for example, students that are doing the diploma, part of their program is they need supervision for one or two cases to get their accreditation or to get their diploma. And I guess wording it in the way that, look, as part of my postgraduate training, I need to do some cases under supervision. You're very lucky. You're going to have two dentists working on you today, right? You've got two sets of eyes, two pairs of hands looking after you, which means that you're going to receive very, 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 very good care. I guess if you've built that rapport with the patient, some of my dentists that I've mentored have said to the patient, look, this is my first implant. I don't want to do it on my own. I'm going to have somebody experienced there with me. And if you're happy to go on that journey, then you will be looked after. If the patient's not, then they offer the patient a referral to the principal in-house or to the specialist or to whoever they want to refer to. Um, and you know your patients, I guess. Some patients, you know that if you ask them or if you say it to them, they're not going to be receptive to it. So maybe they're the patients that you refer. Regardless how easy or difficult the case is, what's more important is the human being attached to that case, right? Sometimes the case is clinically very, very possible and very straightforward, but the patient is a nutcracker, right? That's reality, right? I can't be everybody's dentist, and I need to know where I draw the line with referring certain patients, right? And that's where your specialist colleagues come in. Just send them a box of chocolates or a bottle of wine or something to thank them for the headache that you're about to send them. Um, I have one specialist, when I send him a case, he'll be like, why aren't you doing this case? If you know, you know.
I really like this question that has come in, and you touched on before that there are a lot of complications, and throughout your years, not every case is a slam dunk case. You also have to, manage a lot of things that are less than ideal as well. You spoke about today's standards being tomorrow's mistakes, potentially. Are there any particular techniques or theories or things that you've done in the past that you've had a change of heart about over your career? Philosophies that you adopted once when you were perhaps younger, more naive, that over time have changed your philosophy?
I think I was very lucky in that there's not too many things that have changed in terms of the basic foundational knowledge. I was lucky enough to be starting implants in an era when soft tissue was something that was heavily considered. But 20 years ago, people thought you have bone, you get implants. No consideration for soft tissues. But now, for me, how that's translated is that the first thing I look at when a patient walks in is the soft tissues, right? Soft tissue is always going to be the issue, whether it's aesthetics or whether it's function. So when a patient walks in and says, I don't have any bone, I've been referred to you because I need a bone graft, I say, well, unfortunately, your gums have probably receded as well. So you've been referred for a specific concern, but unfortunately, there are these other concerns that go with it. The soft tissue is a big one. Yeah.
Mm.
I guess when it comes to providing patients with ideal care, we bring everything back down to the patient experience. And when we set up our practice, the one thing that we thought about first and foremost was the patient experience. Okay. So there is a predisposition to immediate implant therapy, for example. Only certain cases should receive immediate implants, and they were these unicorn 3% of patients that had buccal bone that was this big, soft tissues that hadn't receded, essentially a tooth that was virginal and didn't need to be extracted in the first place. That's the ones that you could do an immediate implant on, right? But when you delve deeper into these types of philosophies, you understand that, hey, biologically speaking, people say immediate implants aren't possible in these scenarios, but based on biology, which doesn't lie, which doesn't change, which we need to respect, there are more cases that might be suitable in the correct hands, right? So a change in maybe what cases were possible. And that comes from doing many cases that were within that unicorn range where it's like, all right, they fall into that small percentage of cases that are ideal for this procedure. But then as you do more of those procedures, as Picasso said, you learn the rules like a pro. So then you can know when to break them like an artist, right? And I have this sort of mantra that I live by, and it's always one miracle at a time, sometimes two, never three. If I'm making way too many compromises on a case, then the odds are now stacked against me. Okay. So I'll look at a case and I'll say, yep, bone is good, soft tissue is good, patient's a nutcracker. All right. That's one miracle. If I can manage that, then I can do the case. Bone's not good, soft tissue's not good, patient's a nutcracker, mate. I can't think of a number that's big enough for me to write down to make it worth my time to marry you for the next 7 months.
That's too many coat hangers.
Too many coat hangers, too many miracles at a time.
Yeah.
I like my sleep.
Yeah, that's fair. Can we end this I guess, podcast and this chat with perhaps any stories that you have that you can think of, David. I really like how, I mean, I'm putting you on the spot here. I'm going to ramble so we have time to think. Um, but when Johan shared before about one of his patients that kind of, solidify why you do what you do, any cases that perhaps went well or didn't go well that kind of
Mm,
reaffirm or you think is an important message to
yeah.
share with our
So I can think of two cases.
Hmm,
Um, should we start with the good one or the bad one?
bad one.
Bad one. You didn't even let me finish. Okay. So, like I said, you attract the patients that you tend to develop a niche for, sadly. So I had a patient that needed a single central. Okay. And the first red flag was that her name was Karen. It was red flag number one. So I really just was looking for the second excuse to not treat this patient. But anyway, the second she walked in, she said, I really hate you guys as dentists, right? And you're going to hear that a lot, by the way. We're not very liked. She said, I hate you guys. I'm like, okay, well, we're already on the wrong foot. Well, I need to see you for at least a few months. We're going to need to do at least one surgery. So tell me a little bit about your concerns. Tell me a little bit about how you came here and, where we're at and what are you hoping to expect? We did the consultation. We developed a treatment plan. And then I just said to the referring dentist, look, I need to spend a little bit more time with this patient. Mind you, clinically, very, very doable case. And on 90% of patients that walk through the door, they would have been booked in for surgery after that appointment. But I just wanted to spend a little bit more time with this patient. So we did a Zoom consultation because I was at this practice once a month. So we did a Zoom consultation 3 weeks later after we got a treatment plan. We, did a smile design. We showed her what was possible, etc. And the first thing she said on Zoom is, I really hate you guys. I'm like, I'm not even in the same room as you anymore. So, I mean, for me, that was the second red flag. It was one of those cases where I felt like if I do touch this case, there's nothing that I can do that would make this person happy. Even if I deliver 99% and her expectation is 100%, I failed. I can't meet your expectation. So I referred her to a very good friend of mine and eh, and I got that message, why are you referring this patient? And I gave him the rundown. I always give them a heads up and say, look, the expectation's probably a little bit beyond what I can deliver, even though the dental side is relatively straightforward. He did the surgery. 3 weeks later, she went horse riding, kneed herself in the face, the implant fell out. And I can't explain it. I can't explain, not the horse riding. I can explain that. No, I can't explain what part of me just felt like this patient just turned the other way. We have a very, very hard time in saying no to cases because we want to do the next case. And we want to tackle on cases. And, the egotistical side that dwells in each and every one of us says, you know what, this will be a great case for Instagram or a great case to show your friends and show them how good you are at doing immediate implants, right? So, yeah, the patient became a problematic patient. She ended up blaming the restorative dentist, who's the sweetest human being on the planet that inserted this provisional the day after the surgery, for the failure. You went horse riding, you need yourself in the face. That's one coat hanger I can't control, right? So that was one experience that I was like, you know what, it really reaffirmed, um, I guess, my journey. There was a time when I wanted to do a lot of cases. Now, to be honest, I push more patients out than I do treat. As much as I'd love to do a lot of cases and be there and be the dentist for a lot of people, I just physically cannot. And my mental capacity and my stress levels can only handle so much. So that's where I sort of draw the line on these types of patients. The second case, I guess,
This is the good story.
this is a good story. This was I do a lot of immediate implants now. It's one of the things that I get referred a lot. But this case took 19 months. And I was fortunate for this patient to have landed in my chair because she was a very, very sweet patient. She was very understanding. The process dragged on for 18 months, and every step along the way, we had multiple surgeries, extended periods of provisionalization, arguments with my boss, literally on top of the patient to determine what we're going to do. He was doing a course, I was doing a different course. We had different opinions. And look, at the end of that case, 19 months later, I've probably got about 70 slides worth of education out of that case, and I share this case in some of the immediate implant courses. But because of that case, because of that journey, because of those 18 months of constantly babying the patient through that process, we can now deliver the same treatment in 3.5 months. That doesn't happen overnight, right? It takes 4 or 5 years to become an overnight success. It takes 19, 20 months to be able to do an implant in 3.5 months, right? But I felt like God sort of let me in that direction where I had to go through that learning process. And thank God it was on the right patient, because that on a Sydney patient who expected a front tooth the same day may not have ended the same way. But it was a lot of clinical learning, a lot of patient management learning, which is really, really important. Being able to set expectations to patients um, in that consultation appointment, and reaffirming those expectations every single visit that you have with the patient, and really bringing them back down to their why. I always ask patients, why are you doing this now? I get a lot of patients who are at the end of their sort of dental state. And one thing that always intrigues me is why now? I need to know why now. Because if I know why now, when things don't go to plan, my job is to bring you back to that why. As dentists, we're very technical. We focus on the process rather than the purpose. So our role is to understand the patient's motivations, because we want to bring the patient back down to their why and keep them motivated. Complications will happen. We need to be honest about them. We need to acknowledge them, and we need to baby our patients through them. And some patients need a lot more TLC than others. And I think being able to master that over time is really, really important, because you can foresee when things are about to go wrong, and you can sort of predict the possible complications with a particular case. So if you've already pre-warned the patient that this is likely for them and it happens, you're not providing excuses anymore. You've given them an explanation before it's happened. If you bring it up after the fact, then you're the dentist making excuses for something that you didn't discuss in the consultation or reaffirm at the subsequent visits. Yeah.
That's why we end with the good story. Because I love that how that comes full circle to, I guess, the message we've been sharing in each and every one of our presentations is the dental side of it, the dentistry is one part of it, but it's the patient journey, the patient management, remembering that at the end of the day, as much as you want to do all this crazy work, it's the person attached to it
Yep.
that matters at the end of the day.
And I think control your risk.
Mm-hmm.
Really, control your risk. It's very rare that I see a single posterior implant that is done to perfection, but I see people trying to tackle on anteriors, implants in the aesthetic zone, very willy-nilly. Like a single unit posterior is actually a very, very difficult procedure to do, and you've been able to master and perfect a posterior, which means that when you do an anterior, you're going to carry those skills across. You're going to carry the extraction skills across to the anteriors. You're going to carry the osteotomy protocol to those anteriors. You're going to carry how you look after the tissues delicately in those anteriors.
Yeah.
Yeah.
Wonderful. Well, round of applause. Thank you, Saravakoye, Yuki, for a very enjoyable conversation. Amazing.
And thank you guys so much for tuning in to another episode of the Graduate Dentist Podcast. I really hope you've taken something valuable away from this episode and that you feel heard, you feel seen, inspired, and optimistic about our journey as graduate dentists. As I always say, we're in it together, so let's spread the word, let's share the love, send this to your friends, your colleagues, and those who are on a similar path who you feel may benefit from being part of the community. I'd love to hear your thoughts, so send me a message, and we'll see you again in 2 weeks' time for another episode.